University and a master's certificate in leadership from the Dartmouth Business School, University of Virginia. At USACE, he has different influence on programs and projects valued at $25 billion annually. A professional engineer and a certified construction manager, he was named Person of the Year by the Construction Management Association of America, where he's a member of the College Fellows. Full bios are on the CBIPS website. Thank you both for being here with us today. And now you have the floor.
Just wait, start right stuff.
Well, this is Lloyd Caldwell, and I just want to thank you for permitting George and I to have the opportunity to talk to you about the Corps of Engineers' response to the COVID crisis. We're going to talk less during this time about how we managed our construction during that crisis. We'll be glad to come back at another time and talk about that if you would like. But what we're really going to talk to you about today is how we assisted the Federal Emergency Management Agency and the Department of Health and Human Services to expand the bed capacity to treat patients with potential COVID symptoms. So if we'll go to the next slide, please. We'll talk through this. I'll tell you just a little bit about the Corps of Engineers. I'm going to move pretty quickly so that we can get to the discussion and questions that you may have. Next, please. Many people know the Corps of Engineers in different ways. I'll talk in a moment about the missions that we have, but the purpose of this slide is to really tell you that we view the U.S. Army Corps of Engineers as assisting the nation in addressing the toughest engineering challenges that it may face. And I will tell you that COVID was one of those. So we deliver vital engineering solutions for the nation, not just for the Army, but for every element of the Department of Defense, as well as for many other federal agencies. And we have a worldwide capability, and as you see from the map there, where the red dots are, those indicate places where we have offices that are present. Next slide, please. This collage gives you an idea of the different mission sets that the Corps of Engineers has. One of the things that many people know about the Corps may be from the work we do in our civil works. We have about 13 million acres, over 700 lakes around the nation that we manage for flood control, water supply, recreation, and environmental matters. We also manage and are the design and construction agent for the Department of Defense with their military construction program. And having those two key capabilities gives the U.S. Army Corps of Engineers a unique capability in the nation, which is not held by any other agencies and not held, so far as we have been able to determine, in many other countries in the world. And that's one of the reasons why you see us as an Army command sometimes involved in what we consider civilian activities within the United States. I want to point out on the right side of this slide the contingency operations. I'm going to talk a little bit more about that in just a moment, but when we dealt with the COVID crisis, we were dealing in a contingency operations environment, and we brought the expertise and capability that resides in those other programs that you see there in the collage. We brought those skills to apply to this contingency in a synergistic sort of way. I will point out in the bottom center the geospatial support. That was not insignificant in this case, because one of the things that we needed to do was to be able to foresee where the virus was spreading. And so taking some of the models that were being developed and run by many of the universities, we were able to take that and visualize it in a way that would help us project where we needed to be prepared to be engaged. Next slide, please. We don't do this alone. We, in fact, do virtually everything that we do with industry. And this slide simply intends to make the point that what we accomplish in partnership with industry. We have about 35,000 employees, but if you look at the numbers of contractors that are engaged in our projects, that number is closer to half a billion, more like 500 million. So we have a lot of people engaged in the work that we do, and this is a strong, important relationship for us to maintain with private industry. And let me make a point on this slide about the importance of American industry. Because we work all over the world, we work with other nations, we work with other countries' industry as well. I will tell you that there is no more capable and able industry than what we have within the United States, and that's something that we need to celebrate, I believe, more than we do often. And this COVID response is a primary indicator of that. Next slide, please. I'll speak just briefly about our mission. We had to keep our construction ongoing and our design ongoing during this pandemic. We have over 12,000 active projects at any one point in time, and we required our contractors to put in place new safety standards, to update their accident prevention standards for their projects, and to practice all of those things that we now see being applied across the society, such as social distancing and their work practices and so forth. We are dealing now with the impact that COVID caused to some of our projects, even though in the construction business and in the design business, most of that work could continue. There were impacts, and we have to address those impacts, and that will be addressed over a period of time as we think about how to compensate contractors where they were impacted. Where we worked overseas, there were cases where some of the countries shut down everything completely, and that work, of course, was shut down. And this is something we can come back and talk about another time if you'd be interested. Next slide, please. So I talked about the response to COVID was a contingency operation. The Corps of Engineers is the lead for ESF3, which is response to public works and engineering. So we think of that traditionally when we have hurricanes, when we have tornadoes, when we have floods. You'll often see the Corps of Engineers called in, working for FEMA to help get those communities back on their feet. In this case, we were working under ESF number 8, which is Public Health and Medical Services, where we're supporting Health and Human Services to provide facilities that would permit them to provide the health care. And I would just call your attention down to the bottom of the slide. The diversity of the sorts of requirements that we have found ourselves responding to over the years really provides a very rich capability. You'll see in the bottom that we assisted with the Ebola crisis a few years ago in Africa. We sent teams there to assist in setting up clinics there, and of course we've responded to other international disasters. So that's a normal part of our business, if you will. Next slide, please. This is a review of what we did in responding to the COVID-19 crisis. You will see that we have created over 15,000 alternate care facility bed spaces. We have evaluated over 1,200 sites to be used for alternate care sites, and we're going to talk with you, go through this, about how we made the choices and what we were really doing to attempt to increase the bed space within the United States. Next slide, please. The key point about this slide is to show the places where we had mission assignments from FEMA. And those mission assignments ranged from going in and assessing facilities that could be converted into alternate care sites. So it ranged from those assessments to, in some cases, actually executing the conversion to make an alternate care site. And we looked at primarily 2 or 3 types of sites. We looked at hotels, which were being underutilized during the corona crisis, to convert those. And we looked at arenas or convention centers. And we also looked in some cases at dormitories. For example, Columbia University was one of the first institutes that offered, I think, something on the order of about 3,000 dorm rooms that could be available for the city of New York if that were needed for that crisis response. And in this chart, where you see the black, those are the places where we made assessments. The green are places where the Corps of Engineers built out a new alternate care site, and the blue would be where the state built it out. So the Corps of Engineers built out about 38 sites, and states have built out about 36 sites. Next slide, please. When we talk about the concept of putting in place an alternate care site, the Corps of Engineers had one aspect of that and only one aspect of it. Selecting the site was a local, state, or municipal requirement. They had to get the leases, they had to get the agreements with whomever owned the property they were intending to use. They selected the site. What we did in that case was to assist them in doing the assessments to assure that the site was suitable for use. It will not surprise you to know that in many cases we found that there was asbestos in a building, or there might have been mold or mildew in a building, and of course those kind of things would be totally unsuitable to be converted to a medical site. So there were certain factors that we looked for, and we developed those factors, by the way, that didn't exist before. And then either we would make the conversion, or we would, or the state or municipality would. This is a key point here. Our job, as we envisioned it, was not to go in and have massive construction projects. Our job was to create the criteria and standards that would provide a sufficient design to permit designers and contractors at the local level to go in and convert these to alternate care sites. And then the supplying of equipment, medical equipment, was responsibility of FEMA, Health and Human Services, or the state. And the staffing, which really is the biggest problem in this entire concept, getting the doctors, the nurses, the medical technicians that are required, and getting enough of them was a real challenge. And that is not our responsibility. Next slide, please. We developed an acquisition strategy, and General Todd Simonite did a great job being in the public eye to say, look, we can help. His public meetings brought a lot of confidence, we believe, to people. The second bullet at the top about the requirement, the objective that he established for us was that no person would be turned away from a medical facility for lack of capacity in a medical facility. That was our mantra as we were going out and identifying where alternate care facilities might be needed. The challenge, of course, we all know that the COVID requirements were exceeding the capacity of existing medical facilities. The other thing that we know is that most of the contingency plans for hospitals were based for trauma care. We think of that requirement historically as being necessary for something like a response to a disaster. But now we're dealing with a different thing. We're dealing with infectious diseases. So the sorts of controls that are required in those medical care facilities might be different than what we would normally have in an alternate care standard. And I would say that even though Health and Human Services and other elements of the medical industry had standards for creating alternate care sites, what was lacking in this were actionable standards and criteria that could be given to someone who is not in that business, a contractor or a local official of some sort, and say, here's what you need to do in order to create an alternate care site. And that really is fundamentally what we did. We created those standards and criteria so that these would be actionable sites to be created. And okay, next slide, please. We used our Medical Design Center of Expertise, which has honed its skills for years now in designing medical facilities for both the defense community as well as more recently with the Department of Veterans Affairs. So we have a pretty robust capability of medical architect, engineer professionals that understand how to take the requirements that come from the clinicians and translate that into applicable standards that can go into designs to be built. So they, working with Health and Human Services, developed the standards and criteria that we then published for use, and it was put on an open website. Those standards were published for use by anyone that would want to use them. I will tell you that we even had some expressions of interest from foreign countries, and we've adapted some of those to international building code standards and shared them with other countries as well. We executed the work that we did once we had the standards and criteria. We executed our work through our local districts, which are distributed across the United States. Next slide, please. We used emergency contracts for the most part. The notion was we would take the standard, the city or state would identify a facility. We would have our team with a contractor team walk into that facility, assess on the ground what needed to be done, with the notion that within 72 hours, the contractor would be beginning work in that facility. The specific details of the work would be developed on the fly, and we're going to show you a video in a moment that is going to show you how this ingenuity of the people that work in this business every day are able to get really great results. So I'll point you to that, I think it's the fourth bullet there, objective to marshal the strength and commitment of local and regional businesses and communities. We were overwhelmed with the number of businesses and agencies that were coming to us saying, we can help with this, we want to help with that. We had to set up a special website for that. But the real point is, our objective here, our strategy was to marshal that interest and commitment of those communities to serve their own needs. It becomes critically important too, when you think about these facilities, that there be a really good working relationship with the local code enforcing officials. We can all come up with all sorts of great design ideas, but unless the local code officials believe that it accommodates what their code requirements are, what their community requirements are, we still have a problem. So we had to work together with all of them to get the right results. And all of you can imagine what those are. There, how do you provide fire protection, et cetera. And then we set up systems internally by which we learned over the course of this process and put in place lessons learned. And let me tell you, what we started with and what we were probably doing 3 weeks later were vastly improved. And our battle rhythm here was 7 days a week. We had 2 meetings a day across the entire enterprise. We did that for almost a 2-month period of 7-day-a-week meetings, reviewing everything that was going on and working the kinks out so that things would go smoothly. I'm going to stop there and turn to George.
Okay, thank you. As we just mentioned, we were to put out criteria and standards and actionable tools that was available to municipalities, states, and AEC community at large. We did this through a performance work statement. It was only about 4 to 5 pages long, but it was packed with a lot of criteria that we gained from our medical service expertise, the Huntsville Engineering Center, and our expertise throughout the Corps. We started to do this performance work statement on a Friday, and we're stuck a little bit on terminology and the type care and the division as to how many specs we're going to have, how many standards. We settled on the 4 that are noted on the slide: COVID non-acute for hotel, COVID acute, ARETA healthcare, COVID, ARETA healthcare, COVID acute. We applied we started on the Friday, and we did reviews over the weekend. By Monday morning, we had the 4 standards complete, and we shipped them out to the districts. And by Wednesday, we had our first award at the Javits Center. So we worked pretty quick. One of the challenges we had up front was in terminology, was it the COVID, non-COVID, COVID prevalence, or what type care. We settled on the NFPA standards, 99 standard for healthcare, category 3 and 2, meaning that category 3 would be minor, or be discomfort, cause discomfort, or acute care would be minor injury, and then acute care being negative pressure in ventilator use. Let's go, and there's a link on the bottom there where all the sites that was just mentioned, all the standards are available, and a wealth of information on how we proceeded. Over. Next slide. Okay, here I'm going to just walk you through one of the room plates here, and you can imagine if you put yourself in a hotel, what the room looks like. Normally you have 2 beds, we remove one. We're not looking for a king-size bed, a queen or a double is enough. But the typical hotel room would have probably too much furniture, so a lot of it we did remove. There were some engineering changes that had to be made. And we think about the finishes, the architectural finishes, carpet, electrical. We had to upgrade the electrical systems to a 20-amp circuit. We had to look at the HVAC system, especially if we're getting into acute care, where we're going to drop the pressure down and go for ventilator use and heat the filter exhaust. Emergency power, backup power was a requirement, redundant systems. Also a little vestibule in the opening where, like an airlock chamber, for transition from positive negative pressure for the staff and attending. We had comm systems. We tried most times to use the Wi-Fi in the hotels that were already existing. We could modify the phone systems for nurse call stations. That seemed to work out well. And then if you look at, once you take out everything out of the room, and then the medical equipment came in. So the bed was used. You had the ventilator cabinets, stools, nightstands, linen hampers, and infectious containers, clean, dirty, etc. One thing I'll mention, I just want to show you the room, but with the room, you can imagine you got it on a floor, but then beyond the floor, you have other services we call wraparound services and support. So you have, like, in a hotel, you have an egress, a check-in screening, a pharmacy, cafeteria, staff rooms, break rooms, doffing of personal protective gear, and then you have clean side of the hotel, dirty side. You got site access, you got security, possibly emergency generator power. We started with the intent of having bottled oxygen if required in the room. Then we moved to the exterior site with an oxygen plant and piping, bring oxygen into the rooms. So we kind of evolved, but you think of the whole setup, it's not just one room, it's the entire transformation of the hotel. Some of the things we noticed going into the hotel is that we first had to bring the hotel up to code. When we did the initial assessments, we found out that some of these hotels had deficiencies, and on some of the rooms we found mold in that was remediated. And believe it or not, the largest challenge was the smoking rooms, because almost everything in the rooms appeared to be contaminated, and a lot of them we didn't use. So next slide. Okay, this is just an example of Missouri hotel. You can see it was 118 beds. It was constructed in 4 days, in 9 days from the assessment to construction complete. You can see in the picture there in the lower right that one of the beds has been removed. And again, this is just for visualization. Next slide. Okay, and then if we weren't doing the hotels, we were doing arenas. And arenas were thought, could be a stadium, could be a closed space, open, could be underneath a tent structure, any kind of open floor area. Could we get a pop-up type chair? And it could be typically an medical exam room is 10 by 10. We learned that maybe that's a little bit too much. 8 by 8 might have worked. But we designed the space almost like we did. I just described the hotel room, except we're not removing anything. Nothing was existing. You put up curtain walls, and the medical equipment comes in, and you still have the same concerns depending on the level of care on the electrical and the mechanical system design, meaning that if we were going with the acute care, negative pressure, ventilator, we'd have more engineering changes as opposed to non-acute care. Next slide. The typical layout, this is the patient areas and nurse stations and the pods superimposed on a football field. And you see that each nurse station, we have about 15 patient pods, patient areas, in a U-shape. U-shape, and it varies a little bit, but the U-shape was thought for visibility by the nurse station. And then mechanical and electrical support would be at the exterior perimeter. These would be back-to-back and stacked in runs, large runs, in a modular concept as it's placed as we go forward. And we'll have pictures, and I'll show you the McCormick Center, and you'll get a better visualization out on the video. Next slide. Okay, this is also the Colorado Convention Center, another large build-out we had, or 1,700 bed capacity. One of the things we learned about beds, when we started talking bed capacity, we ended up talking at the end patient spaces, because you know that the president had his daily briefings, and he was talking so many beds, and then if you change from the care from acute to non-acute, or vice versa, the number changes in that for the support and wraparound facilities. But this build-out was complete in 16 days. Next slide. Okay, I want to show you a video real quick. It's McCormick Place, Chicago. It's there were 3 halls. We're gonna concentrate on Hall B, 750 bed medium acuity spaces. The total construction of all of McCormick Place was 26 days. Our Chicago district commander, Colonel Resinger, is the narrator. Let's see if we can go ahead and play the video.
We're in Hall B, and Hall B is the final phase of construction. It's the only one not complete. In Hall B, we're going to have 750 isolation pods, negative pressure with oxygen and vacuum for all of them. I don't know that we completely understood the scale of what we're doing here before we got started on it.
No, so this is a first in the nation to have these. After talking to the providers on what they were looking for, we actually, to do pricing, called out and reached out to about 15 different vendors, and we found these guys, and we got some rough order of magnitude pricing, and we ended up actually passing that information to our contractor, and that's who they bought it from. Again, not understanding everything that would go into that. In these tents we have, as you can see, they duct out through a fan and HEPA filter. And our original thought on that was all we needed to do, but after concerns of how we were going to stage this and people working, it was decided that we were going to duct the air, take it to our main trunk line, and then duct it out of the building. So all of this ductwork is supported by this whole scaffolding system. The scaffolding system also supports the electrical and then all of the copper piping that comes in for inline air and for vacuum. And there's actually one pod of 15 here that they had asked for medical air as well. So a lot of this scope we didn't understand up front, and this was incredibly expensive. The ductwork system for leaving the building was about $7 million, and doing the exterior med gas and bringing it in was about $8 million, and none of that was understood at the very beginning. And I think we came up with a pretty amazing and quick design to give the user what they wanted.
Okay, so the main aspect of these rooms is we can create negative pressure. These were specially ordered out of a firm in Oregon, Eugene, Oregon. And the main components that are in here, here's a HEPA filtration system that will circulate the air out of here at least 12 times per hour. It'll push the air out to the central HVAC system and exhaust it out through fans, and then filter it out before it imparts and it goes outside of the building. The other thing is the headboard is where it provides our connectors for our oxygen and our vacuum, and then it also provides both the basic and emergency power systems here, redundant power systems, what a typical nurse calls the headboard with the bed, and then also an exam light. Because these were pods, part of the construction contract was to ensure we are providing appropriate lighting in each of these pods, so the doctors and nurses can perform their procedures as necessary.
Okay, so my name is Jason, Senior Project Manager for Area B, and what we're doing right now is they are connecting the piping for the medical gas system. Now, the medical gas system being the oxygen, what they're doing right now is brazing them. That torch in that gentleman's hand gets up to about 1,000 degrees. and that is to raise that pipe together. And what you see right next to them is nitrogen tanks. That's medical grade nitrogen. And they place that into the pipe. And then they put it under pressure, and then you can see him brazing it right now. What the nitrogen is able to do is it's able to keep the inside of that pipe clean. There's no burns, there's nothing. So that when he's done, you see the outside of the pipe gets discolored, that's because he's heating it up to around 1,000 degrees, all right? It's just discoloring just the pipe on the exterior, not on the interior. So on the interior, it makes clean. And then after they're done and they have everything brazed, then we will test it with air to make sure there's no leaks. We do that with 100 to 150, we'll have 150 PSI here for 24 to 48 hours and make sure there's no leaks.
Hey, Jason, talk about sort of using the scaffold system as a design feature.
You see this scaffolding system right here. Back when we were tasked with building this facility here, one of the big hurdles we had is you can see the steel for the roof is way up there at 60 feet off the ground, and there was no way to attach it and engineer it and then suspend it. So we came up with the idea to put the scaffolding in here so we can get it quick, and it's engineered to support weight. So we went through behind all these tents, and you see all this scaffolding system that you use, that we typically use for construction, and it's behind all the tents, and then that's our main thoroughfare for the top part is the ductwork. That's all the exhaust ductwork that comes out of the tents. And then we went down and we see all our oxygen and vacuum that's running, and then you see the electrical that's below it. So it worked out great for a racking system. Everybody's given a designated space, and then that's how they delivered all the equipment or the power and all the feeds to each one of these tents that we're using for isolation. All these scaffolding systems are connected. You can see the bridges that came across to suspend to connect the different pods. And then also the scaffolding system is expanded back to those pods, which then proceed outside the back of the building. All this oxygen is connected to a tank farm. We have a tank farm, just like a hospital. And all this vacuum is connected to a vacuum pump that's going to be in a shed, just like a hospital. And then you're going to see these right behind me are the acute tents that have the medical air, and that's going to be attached to a compressor, just like a hospital.
We're not aware Walls Construction is doing our construction. They do hospitals all over the country. I think they have 60 hospital builds going on right now. They're not aware of anything of this scale anywhere. 750 beds with this type of infrastructure that's being put in with the capability that we'll have here in any market.
Okay, one thing to notice here that you notice back there, these are all our zone valves, okay, for the medical gas. These zone valves are going to run directly straight down for all the tents, and that's where we're going to control all the medical gas. And the tanks are just going to roll like this. So these are all your zone valves that will control all the medical gas that feed, I guess, to my right arm all the way down to the front of the space. So that's how we're able to isolate each pod if we did have a problem. On this project, we don't have the opportunity to use the building generator system as it doesn't exist. So we had to put a 1,000 kV generator in to bring all the critical power for just the 750 pods. With that, we had to build this electrical room, which is all 2-hour rated. And you'll see in here the APSs, the transfer switches, and step-down transformers for all the power that's to feed the tents. Each one of the tents gets 4 critical feeds. And then we also have the tank farm and some medical equipment that's on that critical power, as long as the acute ones, which have additional outlets above and beyond the 4 that are in the standard tents for 735. You can see in here, this is no different than any other hospital build that we do. We have the rooms rated, it's all drywall. We put plywood on the walls for them to fireproof, fire-rated plywood on the walls so they can hang all their equipment safely. You can see the scaffolding system is feeding the temporary power that goes outside. You see that scaffolding along the back wall? That back wall takes a turn in the heads and it goes outside to where I'm going to show you guys where the generator's at. We got a generator outside here, 1,000 kV right here. That has the fuel tank inside. That ductwork on top is to exhaust it away from the fresh air intakes right there. Because by code I have to keep it 20 feet away, so that extension of the ductwork, when that thing's running, the exhaust will be far enough away from the fresh air intakes. And all the power is distributed through that panel, that distribution panel, and then through the facility.
So this is a negative pressure tent. This is a HEPA filter system. Pulls the air out, maintains negative pressure in here. It's going to turn it on. If you look at the, come over here and watch the door. Once we close it, you'll see, well, it's already pulling the tent in. It's pull it, and you see how it's pulling like that, so you can definitely see you got negative pressure. My leads, we'll probably make sure we got enough outside air coming in, not to collapse the tent. Yeah. Obviously creating a good seal here inside the tent. Everything seems to be working great. The nurses actually, when the nurses came by and looked at these, they said they'd probably leave just one zipper open. And that's how they would, they're not really concerned about being fully sealed because they know it's pulling air in.
You definitely turn this off and get your airflow through the opening and still maintain negative airflow.
Yeah, absolutely.
I don't think that would be a worry at all.
No, absolutely. And again, this is, this is really all about providing a safe working environment for the healthcare workers. Keep pulling that virus out of the air. You know, the type of patients we have in here, they're going to be vaporizing more often than the low acuity, so they'll be coughing, sneezing more often than the low acute patients, and so there'll be more of that vaporization. And so pulling this out, cleaning that air, and then getting it out of the building is really important for the safety of the healthcare workers.
So as you can see here, this has been an enormous effort here at CONTD as you look over here at the infrastructure that has to be put in place to construct this. You know, but what we're doing here is really creating a lot of confidence for the healthcare workers. Number one, we're asking a lot of volunteers to come work in an environment where you have a lot of patients that are not in great shape. They're moderate acute patients. They potentially could worsen quickly and need rapid care. That's why we created 15 ICU-like pods at the other end, that if they had to really accelerate, have an advanced measures to take, that's why we have med air, oxygen, and vacuum. But one heck of an investment and effort by everybody to get this done, so we provide a safe working environment for healthcare workers, and we provide the best possible care we can to the patients. These are all FEMA assets, so we've purchased these things. This is all, funded through FEMA as part of our mission assignment, our MATO. We're here from McCormick Place. So these are all the FEMA assets when this is said and done. And we'll have to figure out as we go forward what the demobilization plan looks like on this and how we preserve these assets when and if this occurs again. And that's all B.
Okay.
So one of the things we did to the contractors team to sort of work for safety, Jason, stay on in.
Cut it off, right? Okay, that was a quick video of Chicago, McCormick Place, and we learned a lot through Chicago in developing lessons learned were pushed out as the wave continued from the east to the west. We also came up with a containerized solution, thinking that if you didn't have a hotel, you didn't have an arena, maybe there's this one-off to augment an existing medical facility.
Excellent.
Could we go ahead and develop something in a container? Could be stick-built, already an existing off-the-shelf container, and not much different. I won't get into the engineering of it. It would be a HEPA filter design with its self-contained HVAC system. Our lab actually got a container overnight and built out in less than 8 hours the entire structure. We took that team to Detroit, where we thought we were going to utilize 13 of them. That didn't materialize as a contract. We shipped the same team to Washington, D.C., where we actually constructed 6 of these in the southeast quarter of D.C. Next. Okay, some of the best practices we have. We talked a little bit about forecasting models and needs. There were about 5 models out there, and if you list any one of them, like I said in the daily briefings, you got different peak dates. There was the Columbia University had its model. There's the Chimey model out there, and 2 others. But they were off, and what we did is our lab, that Lloyd mentioned earlier, got together and put all the models on a single platform. And one engineer described it looked like a spaghetti dinner in predicting dates and times. But we're able to take all the models on one platform and drill down into a hotspot, drill down into a state, into a county, and look at where the prediction is for peak, what would be the need, so that we could evaluate. And this information was shared with the state, FEMA, and our engineer sources, so we get more fidelity in when the need date is. Because when you're dealing with a construction schedule of 10, 15 days, 1 or 2 days is absolutely critical. On the lower right, we used augmented reality technology in the sense that we were restricted for movement. You think that we're doing 1,000 assessments in a 2-week period of time. We have 15,000 people engaged, almost 1,500 deployed assets, and we have subject matter experts that are learning, and ideally you would like to take the same team to the same building all across the country, but we couldn't do that. So what we did is we had a team of subject matter experts back in the laboratory that were using virtual reality, where we go in and live stream a site and they would come back and then superimpose a solution and stream it back so that the officials on the ground could see it, look at it, and make decisions, go, no go. We talked about the oxygen farm. You can see the one in Miami-Dade County, the largest oxygen tank that I've seen. And then we had a lot of prefabrication of frames for the HEPA filters, and because the HEPA filters became short in supply, it wasn't exactly the size that you needed, that you wanted, and we could frame them together. Next slide. We created negative pressure. It was 0.01 inches of water column, and to make sure that we maintain that pressure, we did have variable frequency drives on the fan motors and pressure monitor sensors with alarms. So that once there was a fault in pressure, we knew instantly. We utilized existing windows and doors and for exhausting the filtered air outside. Next slide. This is where we'll get into a little bit of discussion. I'll talk about some of the challenges we had, but really it's the considerations as we go forward. I talked about the needs, dates, and their speed of delivery was absolutely enough. Talk about speed of delivery with respect to the modular market under the considerations, the capacity to deliver numbers, units, and speed. We tend to default to what we know how to do best, and that's also stick built. We see it go up. We know that we get supplies, materials. Things that are built offsite is almost out of sight, out of mind. But I've talked to a lot of the modular market in the startup of this, contingency endeavor, and that they could deliver 1 or 2 units. They don't have these modular medical pods or clinics standing by. But they could fabricate and deliver, but they couldn't do it in the time frame that we needed or the numbers. Some they could deliver in the speed, but not with the numbers. So that's something to consider because we're trying to get more modular. The thing to note about modular, though, is that we're able to fabricate more and more offsite, like the clean oxygen. When we talk about the supply chain, some of the things we struggle with are lights, medical rated lights, the rating index of 90, CRI, the clean oxygen, piping, and HEPA filters themselves. I talked about terminology and things. I want to get down to the considerations AEC community hospital design. One of the things we're talking about, we're partnering with ASHRAE and our Center of Expertise to come up with a new standard for hospital design going forward. And we found that it's fairly simple to convert a hospital for an entire hospital negative pressure or HEPA filtration if it's designed up front. I mean, there's a challenge to convert some of these as we go forward. But there ought to be some capability instead of develop only one half wing or a wing in itself for isolation to infectious disease. Why can't the whole hospital be turned into it? One of the things we can learn as a community from our civil works program is that we're connected in the waterways. By the water itself, we have dams and hydraulic gauges all the way through, and we have flooding events. We control the level, we control the downstream discharge as we predict what's going forward. And you think about a pandemic, it's almost the same thing. We're not connected by water and physical, we're connected as a society. And perhaps we need to look at the whole medical system as a whole, the region, state, and national, to start designating hospitals as infectious disease where they have 100% isolation, that like we have capacity on the reservoirs and things of that nature, there's a capacity on in the hospitals themselves. Talk a little about the modular market. Energy performance. This came up in the last series with New York. It was a question, and I'd already had it on the slide because it is a concern that here we are trying to build buildings tighter and tighter, limit that fresh air exchange, recircle conditioned air, and in the face of pandemic, you say, no, 12 air changes per hour is what we need. We need to HEPA filter and exhaust 100%, or can we HEPA filter and recirculate? You know, on the pre-filter design, what is the right number for energy performance? You know, and can you build the building for energy performance and then switch over, you know, throw a few switches, and divert, and have something for a pandemic and infectious isolation, negative pressures, et cetera. And the other is the convention centers. If you look at the aerial and you saw it in the video, it almost looks like an exhibit center. But instead of us participating with all our gear, you know, the engineering community, they got hospital beds and their gear. And then you say, okay, is there anything that's reusable? Like the walls themselves, they're almost the same size as a vendor would exhibit. Can the convention centers already have these things? If they're too tall, can they be telescoped? Can they be stored? Can they already be pre-wired, at least one section of it in the back wall type thing? Things to consider as we're moving forward. I was contacted by universities looking for guidance how to open schools. And one of the things I just read that Montgomery County, where we live, is talking about not moving students. And we talked about that, you know, with the other university professionals, where you limit the number of movement into HVAC zones. So instead of designing zones for comfort and function, maybe we need to look at more specifically as ingress-egress controlling zones, so that you can have a group of students that are isolated all day in the same zone, so there's no cross-contamination. You don't have vending machines with people coming in and out and other people that don't belong in that zone. Things to consider as we're moving forward. We're about to release a little white paper on opening up an admin building and how to modify different HVAC systems. We're going to publish that real soon. We're working with the lab and ASHRAE on that now. So that's our presentation. I think we're ready for questions that you may have.
George, Lloyd, what a great presentation. Thank you so much. And you guys just amazed me. 15,000 beds, 38 sites, boom, and they're up and running. You guys are just amazing. Thank you so much. The first audience question is from Ron Lazeev, and you've started to mention it, George, but his question is, in light of your previous approaches or the experience that you've had on your 38 sites, are you looking for more ways that you can add reusable medical capabilities as we need surge capacity or as we come into a second wave?
Yes, you know, the medical packages arrived in containerized containers, wooden crates. A lot of the frame was stick-built or brought on site, but there's opportunity now to box that whole unit up and store it. Now, none of the sites have been broken down yet, but there is discussion as how to break it down, how to reuse, how to store the equipment.
Yeah, Wayne, I would just add to that. When we think about equipping these sites with medical equipment, FEMA and Health and Human Services of some of the states had stocked medical equipment already. As a nation, one of the things that we need to think about is not only stocking medical equipment, but also stocking the facilities now for infectious diseases. Because heretofore, we really weren't thinking of infectious diseases, which as George described, places almost an entirely different set of requirements on creating that medical care than what you would have for trauma care.
Panoski, you're muted.
I'm muted, sorry. Trying to be efficient. So first of all, I just want to say thank you, George and Lloyd, for such a very interesting presentation. A lot of detail, but presented in a manner that was very easy to understand and digest. And the illustrations, the presentation. Thank you so much. I learned so much from you two today, and gained such a great appreciation from the work that you do. I already knew the great work that you did, but you know how quickly you deploy and was able to perform. And like you're saying in your comments and your kind of lessons learned, you were moving so fast that it was difficult for people to catch up with what you were doing. So thank you so much, and thank you, Wayne, also for co-moderating and your questions. I'm combining two questions that we received from the audience. One came from Vinny Fokowski, and another one from Marilisa Esteliano, and they were asking, like, what is the most important lessons learned from this mission that you have? That was what Vinny was asking. And Marilisa was asking, as we are seeing an increase on COVID cases in the South and in the West, what are you doing to work for those increases and cases? And so the question will be, what lessons learned, what was the most important lessons learned that you are using to prepare for the mission as cases increases in the West and in the South?
Let me take a couple of shots at that, and then George will have some other things. We we completed much of our heavy-duty activity by mid-June, if you will. Most of these requirements had been built out or were in the process of being built out by that time. Since that time, within the last couple of weeks, we've had a couple of states that have come back and asked us to assist them in assessing sites where they might want to expand their capability. No one has asked us yet to come in and do any building. We don't think we'll do the building. We think those states will. But we're looking in Arizona, in Florida, in Texas. No surprise, right? In those locations, they've asked us to look at how they can expand their capability. So we're assisting with that. There are two really important lessons. There's so many lessons learned out of this, but one of those important lessons is when you're dealing with a crisis like COVID, you have to stay ahead of it. You can't wait until the crisis exists in a city and then go in and build the facilities because you're too late. So a big part of this is how do you get the right projections so that you're actually getting out about a month ahead of when the crisis is occurring. And I think the other thing I would say is this notion that the requirements will evolve and we've got to be agile to be able to evolve with those requirements. So for example, when George talked about the oxygen tank farm, that was not part of our original plan. The original plan was you'd have bottled oxygen in each room, but it became pretty obvious that that was going to be inadequate, and so we had to go to a different solution. I'll stop there.
Yeah, I'd like to add one thing, because I read almost every lessons learned that came in from our field, and I think one of the things that just repeated itself, and something in the industry we already know, but it repeated again and again, and how important communication is up front, and how important it is getting everybody involved, and that we were not going to be successful if the equipment wasn't on site, and we had to know what the equipment was, generate the list with our partner HHS, so that we could get them ordering it as we're getting ready to build. And the other thing that was nice is that almost everybody at the end of the lessons learned said, this was the most fun I've had in a long time. Everybody was in the trenches together working hard, and it was really the ingenuity of our contractors, you know, that we didn't tie our hands in the spec, but they came up with the solutions that we implemented. And there was enough flexibility in this work statement, the contracting process we had to start and definitize and move forward. It was a lot of fun for a lot of people. Over.
Yeah, well, I'm probably glad I wasn't there. Maybe I'm too old now, but I think it would be fun, yeah. So George, Lloyd, how is the U.S. Army Corps of Engineers going to make their lessons learned available to the public?
Yeah, so many of those lessons learned are on that website that we gave you there. We will have a formal lessons learned package, which probably will not be available for a few months after we're really post-crisis, but right now you can see a lot of those lessons learned on that website.
Yeah. And Wayne, one of the things that we're producing right now we call a playbook that captures all the different phases of the project, all the critical points, and takes a lot of the documentation, the standards criteria, rolls it in, and we hope to publish that soon.
Again, I just want to thank you. We could have spent a lot more time on this. You have enough materials and we have a lot of questions, but it's good, you know, you are making some of the information available to the public, even in draft form. So definitely we will post the link to the website so that people can go and check. And I would like to thank both of you, well, the three of you, Lloyd, George, for, like I said, amazing presentation, so insightful and instructive. And thank you, Wayne, for your participation and your thought-provoking questions. I also would like to thank our collaborating organizations, AZHC New York, AIA New York, ASCE, CMAA New York, New Jersey, CSU, ENR, and NAC. I also would like to give a special thanks to our past speakers and past co-moderators who have joined us today. Dean Anderson, President Emeritus of the New York Building Congress, Eric McFarlane, Deputy Commissioner from Infrastructure at the New York City Department of Design and Construction, Jerry Buckwalter, Chief Operating and Strategy Officer at ASCE, Marilisa Stagliano, Director of Operations of Buildings and Places, Northeast at AECOM, and Vinny Fokowski from the Construction Management Association of America, New York and New Jersey. And of course, a special thanks to all of you out there in offices, agencies, and at home throughout New York City and around the world for taking some time to listen into our lecture today. As we have said in the past, an AIA continuing education credit has been requested for this lecture. If you are an architect seeking credit, the Event Rights registration allows for indication of your AIA membership number. If you do not submit information at registration, please send your name and membership to us at cbips@columbia.edu. Next Tuesday, we follow on our conversation on July 21st. Also from noon until 1 p.m. Eastern Time, we will have the 11th lecture in the series on COVID-19 implications for water reuse. The speaker will be Anna Merotra and Greta Sorns, engineers at CDM Smith. My co-moderator will be Bill Nilek, president of the New York Water Management Association. We understand what the water sector has been doing to look at COVID, the same way that we have looked at the healthcare sector when we saw the presentation last week from New York City Health and Hospital, and today from the U.S. Army Corps of Engineering. On Tuesday, July 28th, we will have the 12th lecture in the series. Our guest speaker will be Nicholas De Nicolo, President and CEO of McDonald North America. And my co-moderator will be Patrick Nathel, President Emeritus or Executive Director Emeritus of the American Society of Civil Engineers. On Tuesday, August 4th, for the 13th lecture in the series, we'll be giving by Victor Ali, responsible for the infrastructure program of the city of Sao Paulo. So now we are moving to the south, to Brazil, Sao Paulo. And my co-moderator will be Luis Carlos Pinto da Silva Filho, Dean of Engineering at the Universidade Federal do Rio Grande do Sul. And on our website, in cbips.engineering.columbia.edu, you can find information about some of our lectures. And of course, I cannot go without saying thank you to all our folks here in Columbia, Rick Bell, Charles Cheng, and Michael Smith for their time and their work. And I would like to say that I would like to thank all of you for participating. And in our website, you can see all the PowerPoint presentations and videos for all the lectures that we have had. And we have put also in the website some thoughts about reopening for workplaces as well as restaurants. So thank you all for joining us today, and please stay well. Thank you so much. Thank you, Lloyd. Thank you, George. Thank you, Wayne, for joining us.
Thank you, Fiona.
Bye-bye.